السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. كل عام وانتم بخير. We will continue our initiative of lecture series, and tonight we will speak about the WHO classification of brain neoplasms. Last time I spoke about imaging of epilepsy, and tonight is brain neoplasms. And next week we will complete our we will complete this series with functional MRI. Then we will start something new. This talk is for education during this COVID period, and it's not for patient care. Imaging not to be reprinted or reused for legality of the institution. Objective of this talk is to give you an overview on WHO classification and to help the audience differentiating brain tumors from mimickers, and to help you how to utilize the imaging findings in giving appropriate differential diagnosis and diagnosis, and to differentiate certain entities based on imaging, and to have little touch on advanced neuroimaging, considering that we will cover it in the next week. In the previous WHO classification, they spoke about brain tumors based on histopathology till 2007. In 2016, they considered the molecular features of the tumor to be in the classification. These are the briefest classification. Started in 1979 till 2007. This is the 2007. And in 2016, it was the molecular features of the tumor and genetic background were included. And it was classified as diffuse astrocytic and oligodendroglial tumors with some modifications in this category. Ependymal tumors, choroid plexus tumors in pediatric and adult, neuronal and mixed neuronal glial tumors, tumors of pineal region, embryonal tumor with modification of the medulloblastoma and others, as I explained, tumors of the cranial nerves and paraspinal nerves, dural tumors such as meningioma with modification, and mesenchymal tumor with also update on it, and others, as I will show you. This is the summary of the major changes in WHO classification 2016 compared to the previous one. What they did basically is using the molecular or genetic parameters in addition to the histopathology of the tumors. Major restructuring and incorporation of genetically defined entities, like diffuse gliomas, including astrocytoma, as I showed you, oligodendroglioma, glioblastoma multiforme, ependymoma variant, and they added novel names to certain tumors, such as diffuse midline glioma, and genetically defined tumors like medulloblastoma and other embryonal tumors, as I will show you. In this edition, they added a criteria to the diagnosis of atypical meningioma, and they added classification of solitary fibrous tumor and imagoperitocytomas compared to previous edition. Addition of newly recognized entities, what they did is considered IDH enzyme to the classification of glioblastoma, either mutant or wild type, and they added H3 histone K27M mutant to the diffuse midline glioma, as I will show you. Also, embryonal tumor with multilayered rosette C19MC altered, ependymoma RELA fusion, diffuse leptomeningeal glioneuronal tumor, anaplastic pilocytic xanthostrocytoma. It was identified, epithelioid glioblastoma, etc. And they deleted certain entities such as gliomatosis cerebri, and it was replaced by diffuse astrocytoma and classified based on its grading, as I'll show you. Also, they deleted primitive neuroectodermal tumor terminology. A touch on the epidemiology of the tumors. We know in adult that the most common is metastasis. Brain metastasis is the most common, and the most common primary brain neoplasm is astrocytoma, considering that GBM is the most common, most prevalent one. In pediatric age group, in young 5-year and less, medulloblastoma is the most common, and older children, astrocytoma is the most common primary brain neoplasm. Approach to giving differential diagnosis and diagnosis based on imaging. First, you should consider the clinical history, age of the patient, and clinical presentation. Then the imaging modality. For example, patient from ER, what I do usually is CT scan, and I do it without contrast, just looking at what's emergency there. And if I see any lesion, then we move to MRI with certain sequences in the tumor protocols. And if we see any pathology that needs further characterization, then we move on to advanced imaging. And based on the location of the pathology and imaging features, we derive the appropriate differential diagnosis, and we help for management planning. As I mentioned, here is CT, MRI, MR spectroscopy, perfusion, BOLD, and VTI, which are functional MRI for pre-surgical planning. Differential diagnosis depends on the age of the patient. For example, in children, the tumors are different from adult. In the location, dural-based tumor different from cortical-based, intraventricular tumors, cellular, supracellular tumors, pineal region tumors, osteofossa tumors, and there are certain tumors which have certain features such as neoplasms with cyst and nodule, and these are, and I'll show some example. This patient has left frontal region mass. First thing we look at, is it intraaxial within the brain parenchyma or extraaxial? If it's extraaxial, then it could be dural-based or rising from the calvarium or subcutaneous tissue, and I'll show examples. How to differentiate intraaxial from extraaxial? The most important thing is to see the origin of the mass. If it's flat toward the dura, then it's most likely dural-based, and to see the CSF cleft separating the mass at all borders from the brain. If you cannot distinguish or separate the mass from the brain, then you should suspect invasion of the brain. And you see the cortical buckling, and within the mass, you see this nodularity. I will show it to you later when we speak about this kind of tumor. This is a patient who has dural-based mass separated from the brain parenchyma. This is a cleft. It has heterogeneous enhancement, some necrosis, and dural base. And dural, it's dural-based mass with dural tail. And this tells you that this mass is rising from the dura, and the most common is meningioma. Meningioma, when it doesn't invade the brain, it's most likely to be WHO grade 1. When it invades the brain, according to the new classification, it will be atypical and grade 2, and I'll show examples of both. Another patient who had headache and diplopia, and we found mass at the midline and the base of the anterior cranial fossa, which is homogeneously enhancing. And when we did MRI, it's seen at the olfactory groove. So this is olfactory groove meningioma, arising from the meninges or from the dura. Another example of meningioma on CT scan showing calcification within the mass, and this is the border toward the brain. It is compressed nerve. Calcifications represent about 25% in 25%, and usually meningioma is hyperdense because of its cellularity, and because of its long-standing presence, it causes bone changes called hyperostosis. Also, it might invade the brain and gives hyperostosis appearance. So hyperostosis could be due to reaction, or it could be due to invasion by the tumor. Another example of mass in the left cavernous sinus, homogeneously enhancing, and when we looked at the bone window, there is hyperostosis. This is another cavernous sinus meningioma. This patient has large meningioma in the right frontal lobe with a necrotic component, giving sunburst appearance, which has central vascular pedicle, like the one I showed you in the previous example here. Central vascular pedicle. This type of meningioma invading the brain parenchyma, so this make it WHO grade 2 or atypical. The most common is WHO grade 1, which is the benign. Atypical is less, and malignant and anaplastic meningioma is very uncommon. Then we move on to other mesenchymal tumors. In the previous classification, it was separated in the as two different entities, solitary fibrous tumor and hemangioblastoma. In 2016, it was put under the same entity, and it was graded into 1, 2, 3 based on the malignancy, as I will show example. This is a patient with solitary fibrous tumor, well-defined surrounding edema and homogeneous well-defined enhancement. This is WHO grade 1 fibrous tumor. This one has large mass invading the brain and involving the subcutaneous tissue, the calvarium, the dura. This is malignant type, so it is hemangiopericytoma, and it's grade 2. And it could be also grade 3 as well. And there is always differential for this. You can consider metastasis, lymphoma, etc. But I'm showing you pathology-proven examples. Solitary fibrous tumor hemangioblastoma, as I mentioned, it was combined and graded into 3 categories. Grade 1, solitary fibrous tumor; 2, hemangioblastoma; 3, anaplastic hemangioblastoma. So another example, patient with stereofossa tumor. Is it intraxial or extraxial? Sometimes it becomes difficult to differentiate intraxial from extraxial, like this patient. But if you see no demarcation, clear demarcation from the brain parenchyma, so you should consider parenchymal invasion or origin, such as this example. And this is metastasis. Patient with metastatic lesion had surrounding edema involving cerebellum and overlying dura. Typically, metastasis is located in the corticomedullary junction, but it can be anywhere in the brain: parenchyma, ventricles, meninges, calvarium, subcutaneous tissue, anywhere, cranial nerves. We should suspect metastasis in adult patients since it's the most common brain neoplasm. One of the features is that metastasis usually gives larger edema compared to others. This patient has left cavernous sinus mass, which is homogeneously enhancing. It's similar to the previous case I showed you. So is it meningioma? We need clinical information. Looking at clinical information, the patient is 52-year-old and has breast cancer. So you should consider metastasis here. And this is metastatic breast cancer in the left cavernous sinus. This patient presented with seizure and headache and found to have this large lesion involving the calvarium, dura, and brain parenchyma. And here the diagnosis is lymphoma, differential is metastasis, since it's the most common. Could it be primary fibrous or mesenchymal tumor? It could be, but common, big common. And this was lymphoma. How to differentiate a mass in the brain with hemorrhage from primary parenchymal hemorrhage? This is a common question, and we face it on the first exam when we see the patient with non-enhanced CT head. But we could differentiate in many ways, either by giving contrast in the acute setting. If it enhances, then it's then there is underlying malignancy. This is one way. Another way is to follow also the lesion. If it started evoluted and the edema started reduced and the hemorrhage started diluted, then it's primary parenchymal hemorrhage. If edema increased and different stages of hemorrhage, then this make underlying mass a possibility on CT scan. But we have MRI, then we should use it. When we do MRI, we focus on gradient images and we see hemosiderin product. And in the post contrast, you might see solid enhancement, and I'll show another example. And multiplicity when you see multiple lesions. And if you see patient with multiple hemorrhagic metastases, then you should suspect the following primaries. Breast and lung, because the most common, thyroid primary carcinoma, RCC, renal cell carcinoma, choliocarcinoma, also melanoma, and sarcoma in young adult patients. So these are the vascular tumor that can give you hemorrhagic metastasis in the brain. This is an example of hemorrhagic metastasis in the brain from thyroid malignancy. And we see lesion in the right parietal and posterior temporal, which shows large hemorrhagic component and nodular solid component. Although it's bright on T1, but still we can appreciate solid enhancement here. You look, this is T1 without contrast, and T1 post contrast, there is solid enhancement, indicating that this is metastasis with hemorrhage. And when you look at the other side, there is another mass here which shows solid enhancement. So this is thyroid metastasis. Another patient, young adult, 26 male with sarcoma. And if you look, there is a vascular mass in the brain, which is metastatic lesion. And when we did perfusion, it's very vascular on the cerebral blood flow. Just showing you, these are the ependymal cells, and this is the astrocyte, and these are the oligodendrocyte, where the astrocyte gives the astrocytic tumor, and the ependymal tumor arises from the ependymal cells, and from here arise the oligodendroglioma or oligodendroglial tumors. Back to our classification. Here is the histology classification of the tumor: astrocytoma, oligoastrocytoma, and oligodendroglioma, and GBM or glioblastoma. When first, this terminology, oligoastrocytoma, is discouraged in the new classification. So the tumor should be classified either astrocytoma or oligodendroglioma. Then we look at the IDH status. IDH is the isocitrate dehydrogenase. If it is mutant, then it is astrocytic tumor IDH mutant, or oligodendroglial tumor IDH mutant. If it's wild, then it's wild type. Otherwise, it is NOS, means not otherwise specified. Same here, glioblastoma, either IDH mutant or IDH wild type. The wild type has poor outcome, as I will show you. Further classification of oligodendroglioma using 1p19q code deletion gives you oligodendroglioma IDH mutant 1p19q code deleted. What is IDH? As I mentioned, it's an enzyme called isocitrate dehydrogenase, and it's a prognostic marker. The wild type has poor prognosis compared to the mutant. Mutant means positive. Here is the previous and the new. So diffuse astrocytoma, IDH mutant, or IDH wild type, or anaplastic astrocytoma, IDH mutant, IDH wild type. The diffuse is WHO grade 2, the anaplastic is WHO grade 3. This is example of that. Patient with right frontal cortical mass, which is hypodense on CT, and you can evaluate the cortex is expanded, although it's abnormal, with no diffusion restriction, no enhancement, and no much edema. So it's most likely low grade. This is WHO grade 2 astrocytoma. Looking at oligodendroglioma, same thing as you mentioned, IDH mutant. Then we further evaluate it with 1p19q code deletion or not otherwise specified. And this is grade 2. If it's anaplastic, then it is grade 3. And this is an example on the oligodendroglioma, large frontal lobe mass, predominantly cortical, all based in the cortex, and extend into the white matter. It shows heterogeneous enhancement. So it's either grade 2 or anaplastic grade 3. Another example of oligodendroglioma showing calcification, which is common in this entity. And as I mentioned, it's arising from oligodendrocyte. Oligoastrocytoma is discouraged, as I mentioned. Another example of glial tumor, low-grade tumor, which is ganglioglioma, based in the cortex mainly. It shows solid nodular enhancement. A typical location is frontal and temporal lobe, and it might have calcification or cyst or mural nodule, like this one. This patient has probably small cystic tumor in the medial temporal lobe with no enhancement. This is typical DNET or dysymperioplastic neuroepithelial tumor, one of the epileptogenic tumor, as I mentioned in the previous talk. Another example of a tumor that has cyst and mural nodule is polymorphic xanthostrocytoma, and in the recent classification, it was classified as WHO grade 2, and when it is anaplastic, more aggressive, it is WHO grade 3. Moving on, this is another patient, 57-year-old with weakness and aphasia, presented with two masses, one in the left thalamus, another one in the left frontal lobe, which are heterogeneous, and the one in the left frontal lobe shows hemorrhages in the gradient images, peripheral nodular enhancement with a necrotic center surrounding non-enhancing signal. This is glioblastoma multiforme, which was classified as WHO grade 4. And I call this signal non-enhancing signal. If you note, it's not edema. It could be non-enhancing tumor. So glioblastoma, as I mentioned. And it has hemorrhages, necrosis, and vascularity. And it shows very low MAA and high CBD values. Here is the glioblastoma IDH wild type, which has poor prognosis and mutant better prognosis. And if we look at the prevalence of GBM, the IDH wild type, unfortunately, is the most common. It's about 90%. And it's seen in de novo GBM. And this explains why de novo GBM has poor outcome and why GBM in older patient has poor outcome, because most of them are wild type. While in young patient or secondary GBM, This is IDH mutant, which has a favorable outcome. This patient has a lesion that involves multiple lobes extend to corpus callosum crossing to the other side. So the differential here is broad. One of it is what we use to call gliomatosis cerebri, but this term is deleted and we call it diffuse glioma, and we grade it based on its malignancy. Differential for this is metastasis GBM lymphoma, but for sake of education, this is diffuse astrocytoma, and it was pathology proven. I want also to show you when you see a midline mass like this, what could it be? It could be a differential, will include lymphoma, glioblastoma multiforme, or metastasis, or other higher grade primary neoplasm. How to differentiate it? On CT, if you see spontaneously dense lesion, then this is this pair for lymphoma for GBM. GBM usually necrotic and hypodense. If it's low on T2, this pair for lymphoma. And when it's solid enhancing like this pair for lymphoma. So this patient has lymphoma rather than GBM based on imaging. Also, when you look at the diffusion, lymphoma tend to restrict compared to GBM. And these are the features that I just mentioned. Pediatric diffuse glioma, we have two tumors I'll speak about. One diffuse midline glioma, used to be named pontine glioma, but now we call it diffuse midline glioma, H3K27M mutant subtype. And GBM in pediatric is different in terms of molecular to adult, and not common in pediatric. So diffuse midline glioma tends to be in the midline, including thalamus, brainstem, and spinal cord as age. Pediatric GBM, it has molecular classification, H3K27M mutation in 34%, and this is very poor prognosis. IDH mutation has good prognosis. IDH wild type has poor prognosis, and it's more common than IDH mutant in pediatric as well. This is the diffuse midline glioma. Example on it, expansile mass in the pons. Embryonal tumors, most common is medulloblastoma, which is genetically defined as WNT activated or SHH activated. SHH activated classified into TP53 mutant or TP53 wild type subgroups. And these are histology or histological classification of medulloblastoma. Classic, desmoplastic, extensive nodularity, and large cell anaplastic. This is example of medulloblastoma, midline mass and exterior fossa, which invade the cerebellum with edema around it, and it shows restriction on diffusion and enhancement after contrast, and it tends to spread along the CSF segment, and usually in younger children, arising from the roof of fourth ventricle, as mentioned, but it invades the surrounding. This patient has mass in the posterior fossa, it's in the midline, large isodense cellular mass with calcification, as you can see, causing hydrocephalus. So what could it be? We did MRI, and the MRI showed that the mass extend along the foramina of Lashka and Magendie. And this is typical appearance of ependymoma, which is the appropriate differential diagnosis for medulloblastoma. So if you see a mass in the posterior fossa in young child, medulloblastoma should be considered, ependymoma, astrocytoma, and other tumors as I will show you. This patient has mass in the posterior fossa, which is aggressive and extensive rotatorially to the mesotemporal lobe and along the dura as well. This is ATRT, which is atypical teratoid rhabdoid tumor, recently described aggressive tumor in young children. And it has poor prognosis and 60% in the cerebellum. It has undifferentiated cells, rhabdoid cells, malignant glia, and malignant epithelial and mesenchymal elements. So it's mixed tumor. And it's also in the differential diagnosis of medulloblastoma. Embryonal tumor with multi-layered rosette. This is new classification, and it was genetically marked with C19 MC alter. So embryonal tumor with multi-layered rosette, C19 MC alter, and the term of peanut was removed. This is an example of it. Aggressive mass in young patient in the right frontal lobe with heterogeneous appearance and heterogeneous enhancement tend to be embryonal tumor. This patient has mass in the posterior fossa, which shows nodular component and surrounding cyst. The nodular component is enhancing. So the differential for a tumor which has cyst and enhancing nodule would include pilocytic astrocytoma, hemangioblastoma. This turned to be pilocytic astrocytoma, which is WHO grade 1, and commonly in cerebellum 40%, 10% brainstem, and it could be also supracellular and other places in the brain. It has very favorable prognosis. Another patient who has sinusitis, etc. But if you look carefully, there is a left cerebellar hypodensity and heterogeneous component posteriorly. When we did MRI, there is a cystic component and solid enhancing component. So this is the cyst, this is the enhancing solid component. Same differential, pilocytic astrocytoma, hemangioblastoma, this turned to be hemangioblastoma. Another example of hemangioblastoma in the spinal cord, this solid enhancing nodule with large syrinx or cord cavity. After resecting this tumor, usually the syrinx will shrink. And same patient has multiple masses in the kidneys, which are renal cell carcinoma, indicating VHL, von Hippel-Lindau syndrome, which is chromosome 3 abnormality. And in this patient, you should check the rest of the body, cardiac rhabdomyoma, and RCC and others. This patient presented with headache, and there is a pineal region mass, either a mass arising from the pineal gland or from other structures. If you look carefully here, here is the tegmentum component of the midbrain, and here is the tictal plate. So this is tictal glioma. MRI showed that the mass is cellular and enhancing. Rule of advanced neuroimaging in brain tumors. One is MR spectroscopy. MR spectroscopy can be done in a different technique. Either we do single voxel, and the advantage of using single voxel is more accurate. It's about 8 millimeter or 1 centimeter up to 1.5 centimeter sampling from certain focus of the tumor where you want to put your voxel. While the multivoxel, you do multiple voxels beside each other, so to give you diffuse sample of the lesion. And in TE, the short TE usually is about 35, but I do use it in tumor. What we use is the intermediate TE, about 144. Some vendor provide 135, but typically 144. And here is breast which is pointed result spectroscopy, or steam stimulated echo acquisition mode, depend on your vendor. This is example, this is intermediate TE, where you see the N-acetyl aspartate at 2 ppm, creatine at 3, and the choline at 3.2. And here is the lactate between 1 to 1.5, about 1.3. This is the normal appearance. When you draw line from NAA to the choline passing by creatine, this is what they call Hunter's angle. In tumor, it will be reversed. The NAA will be low and the choline will be high in neoplasm. This is example of non-enhancing tumor in the mesotemporal lobe. As I showed in previous talk, this is a low-grade glioma. And when we did single voxel spectroscopy, it shows reduced NAA and slight increased choline compared to the normal one. This indicates that it's low-grade glioma. So it's diffuse astrocytoma, grade 2. Grade 1 and 2 are low-grade. Grade 3 and 4 of the primary brain neoplasms are the higher grade. Nothing called intermediate brain neoplasm. This patient with GBM, glioblastoma multiforme, has heterogeneous signal on T2 weighted images, heterogeneous enhancement, and when we did spectroscopy, NAA is very low compared to the low grade one here. So this is high grade tumor. But the best to differentiate low grade from high grade is using the perfusion. Also, it helps you to guide the biopsy and surgery and to differentiate radionecrosis, which is pseudoprogression, from tumor progression or recurrence. This patient has heterogeneous mass in the right frontal lobe, heterogeneous signal with heterogeneous enhancement, hemorrhages, treated, and in the follow-up, we saw this focus here. And on T2 gradient, it has fluid within it, some enhancement. When we did perfusion, there is a lack of or low CBV, sorry, indicating that this is not tumor recurrence. It is post-surgical hematoma. Also, we don't fully depend on the perfusion because of the surgical changes. So we do follow up in close interval, which shows hemorrhages here and resolving of the enhancing lesion. Still, it doesn't mean that there is no tumor, because we know, as I mentioned, that this signal around the primary tumor, it could have tumor cells. It's not edema, it's tumor cells as well. So it can recur. This patient had melanoma, which was resected and got radiotherapy. And when we did MRI, there is a lesion which is spontaneously hyperintense on T1. So is it post-surgical hematoma or tumor recurrence? When we did the perfusion, CBV shows reduced CBV reading, indicating that this is hematoma. So radionecrosis or pseudoprogression, usually in the first year after surgery and treatment, mainly in the first 2 to 3 months, and it keeps growing early, then it drops in its growth during follow-up, as compared to real progression of the tumor. And the patient looks better clinically as compared to patient with tumor recurrence. fMRI, just mention about it, but we'll speak about it next week. DTI and diffusion tensor imaging and BOLD, which is blood oxygen level dependent MRI, used mainly for pre-surgical planning. We localize the motor cortex and language cortex prior to surgical resection when necessary. Also, perfusion, we do it when we need, but in other institutions, they do all of this routinely. Here is task-based MRI, fMRI. Here is the resting, and here is the task, the first period. And when we analyze it, we come up with this signal that help us to localize the eloquent cortex that we are looking for based on the task. And DTI also help us to localize the important tracts when we need. In summary, always you need clinical information, and from ER, as I mentioned, we do just CT. I don't need to give contrast because I'll take the patient to MRI, and we do our MRI sequences, including gadolinium as well. And when we need, we move to spectral perfusion based on what we think. The most important is to be safe physician, giving appropriate differential diagnosis, localizing the tumor and extension of the tumor, mentioning what's emergency, communicating with the neurosurgeon at the appropriate time, and help them to guide the management from your aspect. With this, I'll conclude. Thank you very much. And I welcome you to next week, Tuesday at 7 p.m., speaking about fMRI by expert, Dr. Feroz Mohammed from the United States. I will be looking if there is any question that I can deal with. Okay, I don't see any question from the audience, but I welcome you to any question in the future through social media or visiting our department if you are nearby. Thank you very much and enjoy Ramadan and welcome to the next week. Assalamu alaikum.
في سؤال موجود في الشات يا دكتور.
Where is it?
في سؤال. في سؤال.
Height mortality of pediatric brain tumor. What does it? I am not able to understand this question. What's the mortality? It depends on the, well, pediatric brain tumors are different. There are low grade, like choroid plexus papilloma, WHO grade 1, and there are higher grade, like medulloblastoma. But still, if you treat early and you keep following, the outcome is better than as much as you treat early. There are some tumors which has poor prognosis, like ATRT and maybe embryonal tumor as well. And also depending on the location, some tumor you cannot reach to surgically remove or give radiation, etc. So these are the, or it might, the patient might present with late presentation and seeding of the tumor. This will make it difficult to control. Okay, any other question or comment? Okay, thank you very much. Thank you. I think we will be stop at this point.